Good day, dear students. We continue a course of lectures about tuberculosis. Today, we will discuss about several forms of tuberculosis: focal TB, infiltrative TB, tuberculoma, lung tuberculoma, and cavernous and fibrous cavernous tuberculosis. Please write who are present. And do you listen me? Right, please. And let's start. First form of tuberculosis today, focal TB. Focal tuberculosis is the result of the reactivation of the primary process or reinfection of mycobacteriums of tuberculosis. This form is characterized by small, up to 10 millimeters in diameter foci of productive inflammation, located within 1-2 segments of one or both lungs. That's why in this form of tuberculosis can affect not more than 2 segments on each side. And on this picture, you can see dense foci in the on the apex of left lung, dense foci, and soft focus without clear contours. Okay, I see many students are present. Thank you. And the clinical picture aren't expressed brightly or absent. Because this form of TB is a local form and affected a small volume of lungs. Bacterial excretion is extremely rare in this form, and Mantoux test is usually moderately positive. The hemogram often is not changed. Hemogram as in healthy people, not changed. It can be revealed by digital fluoroscopy in medical check. There are foci of exudative nature with irregular shape, low intensity, and indistinct contours. Fibrous foci of the productive nature are round, medium intensity, and with sharp contours. That's why intensity of soft focal shadows less than intensity of ribs, and intensity of fibrous foci looks like on intensity of ribs or higher than intensity of ribs, because these changes are very, very dense. On this X-ray, you can see group of dense foci in the upper lobe of the left lung. Do you see this foci, density of these foci higher than density of ribs, and contours of these shadows regular. This is dense fibrous foci. On this tomography, you can see the group of soft foci in the upper lobe of the left lung. These foci of middle density without clear contours. On this CT scan, we can see group of soft foci in the left lung, localized subpleural. These focal shadows have not clear borders. On rentgenogram, in this patient, we can see fibrotic foci in the right lung, and you can see all foci on this rentgenogram are very dense and have correct clear contours. This is sign of old process. These foci appear long time. On this tomography, this is one layer of CT scan. We can see a single focus in the right lung, and you can see this focus has clear contours. This is fibrosis. Differential diagnosis of focal tuberculosis with cancer metastasis in the lungs. On this CT scan, we can see several foci, but these foci are very homogeneous and have a correct shape. This sign is more typical for metastasis than for focal tuberculosis. And we can see dense foci in both lungs with clear contours. It is necessary to diagnose the primary tumor for confirmation of metastasis. For this purpose, we used different methods of examination. For example, ultrasound investigation, investigation of abdominal cavity and pelvic organs for revealing of the main tumor. Or can use CT scan of abdominal cavity of pelvic organs. Also do gastroscopy, and it must be consultation of different specialized first of all oncologists. Next form of tuberculosis, name infiltrative tuberculosis. Infiltrative pulmonary tuberculosis is the most common clinical form of secondary tuberculosis of respiratory system. Morbidity amounts about 55% of all cases, for forms of tuberculosis. Infiltrative pulmonary tuberculosis is characterized by exudative inflammatory changes in the lungs with caseous necrosis and presence or absence destruction of lung tissue. Clinical manifestations of infiltrative tuberculosis depends on the prevalence and severity of inflammatory changes in the lungs. And on this picture, you can see areas of caseous necrosis in the lungs. There are 5 types of infiltrates. First type, named lobular infiltrate. You can see this infiltrate on first picture, first scheme, and sizes of lobular infiltrate more often from 1 to 3 centimeters. Next infiltrate, name rounded or oval, looks like on round formation, but without clear contours. And this type you can see on second scheme. Sizes of rounded infiltrates from 3 to 5 centimeters more often. And rounded infiltrate can be connected with lung roots by lymphatic vessels, lymphangitis can form. Next type of infiltrative shadows, name cloud-like, and you can see this type of infiltrates on third and fourth pictures. On third picture, you can see cloud-like infiltrate without destruction. On fourth picture, fourth scheme, you can see cloud-like infiltrate with lightening inside, that's why with destruction. This is cavity of destruction is formed. This type name cloud-like because looks like on cloudy, without shade, without contours, as cloudy clouds. Next type of infiltrative shadows, name labitis. In this infiltrative process can affect all lobe of lung. And labitis you can see on fifth picture. And last type name pericystitis or marginal infiltrate, because this infiltrate localized along interlobar fissure. This is this is a variant of cloud-like infiltrate, but localized along interlobar fissure. Therefore, one border of this infiltrate are not clear. Other border is clear because limited by visceral pleura. And this type of infiltrates you can see in sixth picture. And more detail about each infiltrate. Lobular infiltrate. Clinical picture, asymptomatic. Symptoms can absent in this type of infiltrates. And infiltrate can be revealed on fluorography. On this X-ray, you can see infiltration in the lungs with lymphangitis. Infiltration in first intercostal space between first and second rib. And this infiltrate connected with lung root by lymphangitis. Size of this infiltrate less than 3 centimeters. And infiltrate has not clear borders. On this CT scan, you can see infiltration also infiltration from 1 to 3 centimeter, shadow from 1 to 3 centimeter without clear borders, therefore name infiltrate. It's lobular infiltrate. Next, infiltrate, name rounded. The disease may be asymptomatic or subacute, like acute respiratory infections, bronchitis. The general condition of patients is satisfactory. Good tolerance to high temperature. And on this picture, on this scheme, you can see roundish infiltrate with necrosis inside, and around of infiltrate we can see foci. It's typical for tuberculosis. Roundish infiltrate tend to the delimitation of the inflammatory process. Therefore, it's relatively favorable. On this X-ray, we can see round infiltrate, round-shaped infiltrate. Shape is round, but infiltrate has unclear borders, and inside of this infiltrate we can see lightening. Therefore, we think about destruction inside of infiltrate and about formation of cavity. On this tomogram, we can see roundish infiltrate also, without clear contours and with lightening inside. This is infiltrate, rounded infiltrate in stage of destruction. And calcified paratracheal lymph nodes we can see also on this tomography. This is old changes, and this is a source of secondary reinfection of tuberculosis. On this rentgenogram, we can see infiltrative shadow in the right lung, upper field of right lung, upper field and external zone of the right lung, without clear contours, shadow from 3 to 5 centimeters in diameter, and inside we can see formation of cavina, cavity of destruction. Later can form caveinous tuberculosis from this cavity. Here on this rentgenogram we can see roundish infiltrate also, localization in projection of lung root, near lung root in the right side, and we can see roundish infiltrate without clear borders and with lightening inside. This is destroy of lung tissue. This is rentgenogram and tomogram of one patient, and we can see on rentgenogram infiltration. On tomography can see cavity of destruction inside of this infiltrate. If we have doubtful about formation of cavity, When see on X-ray, we should do tomography for confirmation of destruction in the lung tissue. Destruction better to see on tomography and on CT scan. Here on this CT scan, we see roundish infiltrate with destruction inside and with focal shadows around of infiltrate. Focal shadows around of infiltrate confirm tuberculosis because this is dissemination of mycobacteriums around of infiltrate. This sign typical for TB only. This sign is not typical for pneumonia, for abscess, etc. Only for tuberculosis. On the CT scan, you can see roundish infiltrate also connected by lymphangitis with lung root, and inside of infiltrate can see destruction, formation of cavity, and around of this infiltrate we can see focal shadows also. The same on this CT scan can see roundish infiltrates also with destruction. Next type of infiltration, cloud-like infiltrate. Looks like on cloudy, therefore has name cloud-like. The disease can start acute or subacute. Clinical picture, intoxication and pulmonary syndrome. The general condition of patients is satisfactory, relatively good tolerance of high temperature. And cloud infiltration is not inclined to the delimitation of the inflammatory process, therefore proceeds with a more severe clinical picture. On this rentgenogram, we can see infiltrative shadow, more than 5 centimeters in diameter without clear borders and without any tendency to delimitation. Here we can see cloud infiltrate also with lymphangitis to root of lung. That's why shadow connected with lung root. This sign is typical for tuberculosis connection, lymphangitis, but is not typical for non-specific pneumonia. In non-specific pneumonia, lymphangitis is not formed. Next type of infiltrative shadows name pericesuritis, because or marginal infiltrate. What means pericesuritis? This infiltrate localized along caesura, along fissure. Therefore, one border of this infiltrate is not regular. Other border is regular because limited by visceral pleural. Limited, that's why limited by fissure. And in these type of infiltrates prevail pain in the chest because visceral pleura is affected also. On this X-ray, in lateral view, you can see infiltration of the upper lobe along the main fissure, and lower border of this infiltration is clear. Upper border is not clear. It's not limited. And on tomography in this patient, we can see infiltration with lower clear border and upper unclear border. This is tomography of cloudy infiltration. You can see infiltrative changes in lung tissue in the left lung. This is upper lobe of the left lung. Infiltration of upper lobe. And last type of infiltrates named labid, because this is inflammation of one lobe of lung. All lobe of lung is affected in this type. The disease begins acutely, like pneumonia. Clinical picture, intoxication and pulmonary symptoms. Dyspnea, cough, initially dry, then with sputum, hemoptysis, temperature up to 38.5 degrees, weakness and sweating. On this picture, you can see the tuberculous process affects the lung lobe with formation of cavities of destruction. The process is not prone to separation, occurs with severe clinical picture. On X-ray, in this type of infiltrate, we can see decrease of pneumonization of all lobe of lung. One lobe of lung. On this X-ray, we can see affection of upper lobe of the right lung with regular lower contour. Lower border is regular. This is localization of horizontal fissure. And this fissure limited upper lobe. The most often labidis can affect upper lobe of the right lung. This sign you can remember for differential diagnosis, because 70% of all cases, in 70% of all cases, affection of upper lobe of the right lung confirm tuberculosis. Later, rarely can form non-specific processes in upper lobe of the right lung. This is more typical for tuberculosis. On this X-ray, you can see affection of upper lobe of right lung also. Decrease of pneumonization of upper lobe we can see. And on CT scan, we can see affection of upper lobe of right lung also with cavity of destruction, with cavina in both projections. What the main differential diagnosis of infiltrative tuberculosis? First of all, we should differentiate this form of TB with pneumonia, because on X-ray we can see infiltrative shadow in both diseases. On X-ray, these diseases are looks like. And if we see this picture on X-ray, infiltrative shadow, we should investigate a sputum for revealing of mycobacteriums of tuberculosis. If we not found mycobacterium of tuberculosis in sputum, and on X-ray see infiltrative shadow, we should use non-specific treatment with antibiotics of wide spectrum of action during 2 weeks, except fluoroquinolones and aminoglycosides. Better to use other groups of antibiotics. And on this X-ray and on CT scan, you can see infiltrative shadow. On CT scan, infiltrate looks like on frosted glass. Next differentiation, atelectasis of a lobe of the lung. For confirmation of this problem, we should use different methods of examination. For example, computer tomography, bronchoscopy, and biopsy of the mucosa of the affected bronchus. And sometimes we can reveal in bronchoscopy different problems. For example, on this photo you can see the tumor which blocking a bronchus, and as a result can form atelectasis. Next form of tuberculosis named acacious pneumonia. Before the era of anti-TB drugs, had a 100% mortality rate. It's very, very hard form of tuberculosis. The process extends beyond the lobe of the lung. Exudative necrotic reaction dominance are with quick purulent melting of the lung tissue, formation of multiple cavities with no tendency to delimitation, which forms a giant cavity of destruction by mergering. And on these macro preparations, you can see caseous mass, caseous necrosis of the lung. White color, this is caseous necrosis. clinical symptoms of gaseous pneumonia. Intoxication syndrome is sharply expressed. Temperature about 39-40 degrees with profuse sweats, severe weakness, repeat weight loss to cachexia, and inadequate behavior. Pulmonary symptoms: cough with sputum from 200 to 250 milliliters or more. This is high quantity of sputum. Shortness of breath at rest. In the later stages, reaching up to suffocation. Mantox test is negative more often in this form of TB because immunity is low. The blood and urine toxic. That's why we can see signs of inflammation in the peripheral blood test, general blood test, increase of leukocytes, ESR increase, and in urine we can find signs of toxic kidney. This is erythrocytes, leukocytes, proteins, and hyaline cylinders. Signs of urine toxic urine. Sorry. On X-ray, in this form of tuberculosis, we can see total infiltration of the lung tissue and affected more than one lobe. We can see infiltration of more than one lobe. On this X-ray, you can see infiltration of the left lung. All lung is affected, and affection of opposite lung. In middle parts of the right lung, we can see infiltration also. Process more than one lobe. On this rentgenogram, we can see giant caverns in the right lung and in the left lung, polycaverns, multiple caverns, and infiltration around them. On this CT scan, we can see infiltrative changes in the lung tissue, right side, right lung, large infiltrate, and we can see infiltrates and focal shadows in opposite lung, in the left lung. Here we can see caseous infiltrative shadow in the left lung, caseous masses in the left lung, and many massive caseous necrosis and many focal shadows around this picture with cavities. This is picture of caseous pneumonia. And next form of tuberculosis, named lung tuberculoma. Tuberculoma is encapsulated caseous focus volume more than 1 centimeter in diameter. That's why this is affection more than 1 cm in diameter with clear this is encapsulated formation, more than 1 cm in size. And there are several types of tuberculomas. First type, name infiltrative pneumonic. Second, homogeneous type. These types, infiltrative pneumonic and homogeneous, can form from infiltrative tuberculosis, for example. Next type, name layered. And this type of tuberculomas can form as a result of progressive duration of tuberculomas. Next type, conglomerate tuberculoma, can form as a result of fusion of several foci after disseminated tuberculosis, for example, or after focal tuberculosis. Several foci can join together and surrounded by general capsule and form conglomerate tuberculoma. And last type of tuberculomas named pseudotuberculoma. This is not tuberculoma. This is full cavina. Drainage bronchus of cavinas can blocked, and caseous mass can accumulated inside of cavity. And on X-ray, in this case, we can see formation looks like on tuberculoma. Tuberculoma is detected like around the shadow with clear contours on rentgenogram. Enlightenment may be determined in focus because of decay, sometimes on the periphery of the focus. Tuberculoma can be single and multiple. Other classification of tuberculomas according sizes. There are small tuberculoma from 1 to 2 centimeters in diameter, medium tuberculomas from 2 to 4 cm, and large tuberculomas more than 4 centimeters in diameter. Sometimes can form giant tuberculomas, sizes of these tuberculomas more than 6 centimeters in diameter. And on this photo, you can see macro preparation. This is part of lung after resection, after operation. And here you can see 2 tuberculomas, infiltrative pneumonic type. This is caseous necrosis inside of tuberculomas, caseous mass. There are 3 types of 3 variants of the clinical course of tuberculoma. First, regressing, when tuberculomas decrease in size. Stable, when tuberculomas, sizes of tuberculomas not change. And progressive, when sizes of tuberculomas increase. And in regressing variant, a clinical picture is satisfactory. Clinical symptoms are absent. In stable variant of clinical duration, clinical symptoms can absent also, and tuberculoma sizes of tuberculomas is not changing. And in progressive duration, clinical symptoms are present, and tuberculoma increase in size. On rentgenogram, we can see in this form of TB round formation. That's why this is this shadow named round shadow. This is shadow more than 1 cm and with regular contour, regular border, clear border. This is encapsulated formation. And on this X-ray, we can see large homogeneous tuberculoma, round formation in the right lung. Around of this formation, we can see focal shadow in lower part of this tuberculoma, focal shadows. And this is confirmation of TB etiology. On this rentgenogram, we can see round formation also with lightening inside. This is a large tuberculoma. And also we can see method of treatment of destructive processes on this X-ray in lower parts of the chest. This method of treatment name artificial pneumoperitoneum. This is injection of air into abdominal cavity. When we enter gas into abdominal cavity, lungs compressed and destructive process can close more fast. On these tomograms, we can see round formations also. On the left tomography, we can see homogeneous round formation, homogeneous tuberculoma. On the right photo, we can see a round formation also, but this formation is very, very dense with islands of petrification. This is calcified tuberculoma. On this tomography, we can see conglomerative tuberculoma. This tuberculoma, I repeat, these tuberculomas can form as a result of fusion of several foci, which are surrounded by general capsule. These tuberculomas can form after focal and disseminated tuberculosis. On this CT scan, we can see round formation. This is tuberculoma with lightening inside. That's why this is tuberculoma in stage of destruction. And you can see this tuberculoma connected with bronchus. On next CT scan, we can see homogeneous tuberculoma also. What differentiation of tuberculomas of the lungs? First of all, differentiation with echinococcus of the lung. On this X-ray, you can see round formation. In the left lung, looks like tuberculoma, but on CT scan, in this patient, we can see shell echinococcus bladder. Next differentiation, hamartoma of the lung. This is benign tumor. On X-ray in anterior position, we can see round formation near lung root. And on tomography, CT scan, computer tomography, in this person, we can see dense inclusions in the contents of the tumor. This is hamartoma of the lung. Next, differentiation. Field lung cysts. On this X-ray, we can see dermoid cyst of the lung. Inside of this cyst, fluid. Therefore, we can see round formation. Looks like on tuberculoma. And on CT scan, in the right side, we can see right photo in the left lung. We can see retention cyst of the lung. This is formation with fluid. Therefore, looks like on tuberculomas. Next differential diagnosis with peripheral lung cancer. Peripheral lung cancer on X-ray can be like to tuberculomas also. And on CT scan, in the left photo, you can see nodular formation connected with the root of the lung. For differentiation, for differential diagnostic, we should use different methods of examination, especially CT scan with contrast substance and bronchoscopy. In bronchoscopy, we can see changes in the bronchus and can take material for histological investigation. The main method of differential diagnosis of roundish formations in the lungs, the operating biopsy. Better to do operation and investigation of post-operating material for biopsy and histological investigation. Okay, let's do small break now. 5 minutes, and after 5 minutes we continue lecture. And dear students, let's continue our lecture. Next form of tuberculosis, cavernous pulmonary TB. Cavernous pulmonary tuberculosis is characterized by the presence of the formed cavity and without severe fibrotic changes in the surrounding lung tissue. This is formation of cavernous with thin wall. Cavernous tuberculosis develops from infiltrative, disseminated, focal tuberculosis, tuberculoma, when the phase of decay ends with the formation of cavities and signs of the original form disappear. That's why cavernous can form after other forms of tuberculosis as a result of destruction of the lung tissue. Here on macro preparation, you can see opened cavern of the lung. Clinical picture in remission. Pulmonary syndrome can present, recurrent cough with mucus sputum only. And clinical picture in the period of exacerbation or in acute period. Intoxication syndrome appears. Bacterial extension can be detected. That's why in sputum analysis we can find mycobacteriums of tuberculosis in this period. On photo and on scheme, you can see cavity in the upper lobe of the right lung. On X-ray, cavernous pulmonary TB characterized by presence of ring-shaped shadow. That's why the main X-ray symptom of this form of TB is ring-shaped shadow. On this X-ray you can see giant cavity with thin walls. This is ring shadow. Looks like on ring. Without changes around of cavernous. On this X-ray, we can see medium cavernous after infiltrative tuberculosis, because around of cavernous safe signs of infiltration, perifocal infiltration, safe. Ring shadow also. On tomogram, in this person we can see ring shadow also. This is single cavity in the upper lobe of the left lung. Changes around of cavernous are absent. Infiltration absent. On this layer of CT scan, you can see large cavernous after infiltrative tuberculosis. Around of cavernous, you can see perifocal inflammation. That's why this cavernous form after infiltrative TB as a result of destruction of lung tissue. And do you see this cavernous, this formation, this cavity is empty, contains absent inside of cavernous. This is typical for cavernous tuberculosis because drainage in this form is formed. connection with drainage bronchus. On this CT scan, you can see single cavity after the collapse of the tuberculoma. That's why cavina formed after the destruction of tuberculoma in this patient. On this CT scan, you can see cavina also, single cavina, and around of cavina we can see infiltration. On this CT scan, we see bilateral stamped cavities after disseminated tuberculosis. That's why formed cavinas in both sides, in symmetrical parts of both lungs, and we can see them on one level. Next form of tuberculosis. This is destructive forms of tuberculosis, caveinous and fibrous caveinous TB. Fibrous caveinous tuberculosis of the lungs is characterized by the presence of fibrous cavities, development of fibrotic changes in the surrounding lung tissue, pulmonary fibrosis, emphysema, and bronchiectasis. And on photo in the left side, you can see fibrous cavity with bronchial dissemination. That's why around of cavina, around of cavity, many white dots. This is caseous foci dissemination. Fibrous caveinous tuberculosis forms from infiltrative or disseminated caveinous process in a progressive course of the disease. That's why, as a result of progression of different forms of tuberculosis can form fibrous caveinous TB. The process can be unilateral or bilateral, with the presence of one or more cavities. On this picture, you see fibrous cavity with bronchial dissemination. In the left side, we can see fibrous cavities and dissemination around them, and dissemination, lymphogenic dissemination in the opposite lung, in the right lung. You can see also. Clinical picture of fibrous caveinous tuberculosis is diverse. It depends on tuberculosis process and the complications. Here you can see fibrous cavities and dissemination in both lungs, and fibrosis of the lung tissue around of cavern. Also, in the lower part of the left lung, we can see emphysema and bronchiectasis. This is macro preparation. There are two variants of clinical duration of fibrous caveinous tuberculosis. First variant, limited and relatively stable, when affected small volume of the lung. And progressive, second variant, progressive because of violation course of treatment. Here you can see histological preparation and fibrous cavity. You can see cavity is surrounded by fibrosis. On X-ray, in this form of tuberculosis, we can see four the main X-ray signs of this form. First sign, fibrous. First sign, cavina or polycavinous. Second sign, fibrosis around of cavina or cavinas. Third sign, shift mediastinum and trachea to the affected side. That's why mediastinum shift to side with fibrosis. And fourth, the main sign on X-ray is bronchogenous dissemination. That's why we can see many focal shadows in both lungs. This is result of bronchogenous dissemination. And on this X-ray, you see fibrous giant cavity in the upper lobe of the right lung, surrounded by fibrosis, and in both lungs we can see focal shadows, many focal shadows of different density, different sizes, and we can see shift mediastinum to the right side because upper part of right side contain fibrosis, form fibrosis in upper part of right side. On this X-ray, we can see multiple cavities in the left lung, sorry, not right, left lung, and fibrosis, and shift mediastinum to the left side, and many focal shadows in both lungs. All four the main X-ray signs of fibrous cavernous pulmonary tuberculosis are present on this X-ray also. The same, polycavinous in the right side, cavina in the left side, fibrosis around them, dissemination in both lungs, and traction of trachea to the right side because process prevail in the right side. Fibrosis prevail. Trachea shift to the right side. On this X-ray, we can see all signs of fibrous cavernous TB also. Polycavinous in the left lung. Mediastinum is displaced to the affected side and total, as a result of total fibrosis of the left lung. And in the right lung, we can see many focal shadows. This is bronchogenous dissemination. Also, on this X-ray, we can see additional signs of fibrosis. Decrease, for example, decrease of the left hemithorax as a result of formation of connective tissue. Lung tissue change to connective tissue. Decrease of intercostal spaces. If we will compare symmetrical parts of lungs, we can see in the left side intercostal spaces less than in the right side. Apex of the left lung decrease, shift to down as a result of fibrosis also. On this X-ray, we can see affection of upper lobe of the right lung also. This is formation of cavity with fibrosis around. And we can see upper lobe of the right lung decrease in size as a result of fibrosis. Also, trachea shift to the right side as a result of formation of fibrosis in the right side. And in the left side, left lung, we can see formation of emphysema. This is compensatory mechanism. One side decrease, other side increase. On this X-ray, we can see ring shadow with thick walls and total dissemination in both lungs. This is result of lymphobronchogenous dissemination and lymphomatogenous dissemination in both lungs. On this X-ray, we can see giant cavity in the upper lobe of the right lung, surrounded by fibrosis, white color. This is fibrosis around cavina, and focal shadows in the middle and lower lobe of the right lung fused together. And this is bronchogenous and lymphobronchogenous dissemination. Displays mediastinum to the right side also. On this tomography, we can see giant cavina, empty inside with clear internal contours, and fibrosis around of cavina. Lung tissue changed to connective tissue. Therefore, left lung decrease in size and shift trachea to the fibrosis. We can see also on this tomography. This is sign of fibrous cavernous TB. Sometimes inside of cavina can grow aspergillomas. This is result of long time treatment with antibiotics. Fungus can grow inside of fibrous cavinas. And we can see dense formation inside of fibrous cavina on the left side. On CT scan, in this patient, we can see large fibrous cavity, also with thick wall, with fibrosis around. Cavina is deformed by fibrosis, and infiltration and dissemination we can see also in this patient around of cavina. In the right lung, we can see large fibrous cavity, cavity with thick wall deformed by fibrosis around of cavina. And what the main differential diagnosis of fibrous cavernous pulmonary tuberculosis? First, lung abscess. We should differentiate it with lung abscess. On this X-ray, we can see lung abscess with a cavity with fluid and horizontal level of fluid we can see. This is typical for lung abscesses and not typical for cavinas. Cavinas we can see on X-ray empty more often because cavinas, through tuberculous cavinas, have drainage bronchus and contents of cavina can evacuate it through bronchus to environment. Here we can see lung abscess also with fluid with horizontal level. And chronic lung abscess without fluid, without changes around of cavity, without dissemination, without fibrosis. This is drainage abscess, after drainage. This is chronic lung abscess on CT scan. Next, differentiation with lung cancer. On X-ray, we can see cavity in this disease. Very looks like on cavity with fluid. And lung cancer in last stage, in fourth stage, can be like to fibrous cavernous tuberculosis. Because from cavina also. On this tomography, we can see cavitary form of peripheral lung cancer. Looks like on fibrous cavernous tuberculosis also. Next, echinococcus. Next differentiation, different lung cyst. For example, on this X-ray, you can see echinococcus cyst of the lung with contains inside. We can see cavity with contains with horizontal fluid also. This is drainaged echinococcus cyst of the lung. Looks like on cavina. On this X-ray, a single air cyst of the lower lobe of the lung. Also looks like on cavina, cavernous TB. On this CT scan, we can see multiple lung cysts in both lungs. This is cystic lung hyperplasia. Looks like on polycavernous. And this is cystic lung hyperplasia also. Many cavities with thin wall in the right lung. And the next differentiation, bronchiectasis on CT scan can be like on fibrous cavernous tuberculosis. But this is bronchiectasis. Next form of tuberculosis, cirrhotic pulmonary tuberculosis. This is destruction form of TB also. Can form after other forms of TB also, and cirrhotic tuberculosis of the lungs is the overgrowth of coarse connective tissue with coarse connective tissue with lesion of the lung and pleura. It's the result of the involution of fibrous cavernous, chronic disseminated infiltrative tuberculosis of the lungs. That's why I can form after other forms, destructive forms of tuberculosis. And on this picture, you can see cirrhotic pulmonary tuberculosis with many cavities of destruction and cirrhosis of upper lobe of the right lung. Cirrhosis with many cavities. Cirrhotic tuberculosis is characterized by tuberculous changes in the lungs with clinical signs of active process, tendency to periodic exacerbation, and sporadic poor bacterial extension. Cirrhotic pulmonary tuberculosis in cirrhotic pulmonary tuberculosis can form multiple small cavities. You can see these cavities on form of connective tissue on macro preparation in this photo. On this X-ray, we can see cirrhotic tuberculosis of the upper lobe of the left lung. This decrease of lung, upper part of lung, and shift of trachea and mediastinum to the affected side as a result of formation of connective tissue. On this X-ray, also upper part of the right lung is affected, decrease in size. We can see shift of interlobar fissure to upper as a result of formation of cirrhosis in upper part of the lung. Cirrhosis of upper lobe of the right lung also on this X-ray we can see shift trachea and mediastinum to the cirrhosis to the right side. This is outcome of infiltrated tuberculosis. That's why cirrhosis is formed after infiltrate. On this X-ray, we can see cirrhosis of the left lung. The mediastinum is shifted toward the cirrhosis. Cirrhosis of the upper lobe of the right lung. On this tomography, we can see decrease of pneumonization of upper lobe and decrease in size. And on this tomography, we can see cirrhosis of the lower lobe of the left lung. And we can see emphysema, bilious emphysema in the right lung. On this tomography, we can see cirrhosis of the upper lobe of the right lung. Looks like on TB cirrhosis also. Next differentiation of cirrhotic tuberculosis, the tumor of the upper lobe of the right lung. That's why we should differentiate it. TB cirrhosis with tumor processes, oncology processes. Can be like to cirrhosis also. On this tomography, we can see pancreas cancer on tomography. Looks like on cirrhotic tuberculosis also. And for differential diagnosis of cirrhotic lung tuberculosis with other processes in the lungs, other diseases, we should use different, for confirmation of diagnosis, we should use different methods of examination. And this is computer tomography, bronchoscopy with study of flash water of Mycobacterium of tuberculosis. If we found Mycobacterium tuberculosis, we can confirm TB etiology Next method, pleural puncture with taking the material for suturing Mycobacterium of tuberculosis and malignant cells, atypical cells. And next method, biopsy of peripheral lymph nodes. We can investigate it, axillary and cervical large lymph nodes. And the most accurate diagnostic, operating biopsy. Do operation, resection of part of lung with problem, and investigated this material do histological investigation. For confirmation of tuberculosis, in this method of examination, we should find giant Langerhans cells. This is confirmation of TB etiology also. If we not, that's why if we not found mycobacteriums of tuberculosis, we can do biopsy with histological investigation, and if we found giant Langerhans cells, it will be confirmation of TB also. Thank you for your attention. Today lecture, and see you next time. Thank you for your attention. Goodbye.